This topic is on thyroid gland. So this is when you dissect, you start with removing the skin, superficial fascia, the platysma, you're removing it. Then you see the deep fascia. Then you see these muscles, suprahyoid muscles, infrahyoid muscles. Let us quickly revise. The suprahyoid muscles are the muscles which lie above the hyoid bone. They are the digastric and the stylohyoid. If you can see, the stylohyoid muscle is always seen with the posterior belly of the digastric. Okay. Then there is a mylohyoid muscle, this one, and geniohyoid, which is not seen here. Below the hyoid is the infrahyoid muscles. So they are the omohyoid and the sternohyoid. Once we remove this, then we will see the sternothyroid and thyrohyoid. So this is a thyroid cartilage which has got this oblique line. This is the digastric muscle and this is the hyoid bone. Sternohyoid, thyrohyoid. This is the thyroid gland. Okay, this is the thyroid gland. So thyroid gland is a highly vascular organ lying anteriorly or in front and sides of the neck. It has got two lobes. It is joined by isthmus. It lies deep to the sternohyoid muscles. Okay, and it lies along the C5 to T1 vertebral levels. Whenever you're writing a short note on thyroid, you have to cover this location. So vertebral level also you have to mention. The thyroid gland is covered by two capsules, that is true and false. True capsule is always formed by the stroma. So true capsule will be formed by the condensation of the fibrous stroma of the gland. प्रोस्टेट में भी अगर देखोगे ट्रू कैप्सूल जो होगा वो स्ट्रोमा से ही बनता है. And false capsule will be either the peritoneum, and here in this case it will be the deep fascia. We have seen it just now. Okay, enclosing two glands. So one gland is the thyroid gland. Okay, so covered by the capsule we said. Now, if you can see in this diagram, the venous lies beneath the true capsule. So whenever I want to operate on the gland and I want to remove the gland, I'll see to it that I am removing it along with the true capsule. If I leave the true capsule, there will be a lot of bleeding because the venous plexus lies here. Okay, so I will leave the false capsule intact and remove the gland with the true capsule. Whereas in prostate, it is totally different. In prostate, the venous capsule or venous plexus lies in between these two capsules. Okay, so here we will have to remove the gland along with the false capsule. MCQ as well as Viva. Okay, we were saying about ligament of Berry. Now, if you see that, we know that false capsule is formed by splitting of the pretracheal fascia. It is enclosing the gland. It is attached to the hyoid bone as well as the oblique line here on the thyroid cartilage. This false capsule is thickened medially and it forms the ligament of Berry, which is attached to the cricoid cartilage. So this is the ligament of Berry or suspensory ligament of Berry. Here, this is the one. So the lobe is attached medially to the cricoid cartilage, and that is the reason why the thyroid gland moves with deglutition, asked in your exam. The presenting part of the gland, this is the thyroid gland, two lobes and the isthmus. See, conical in shape, apex pointing upwards, base pointing downwards. If you see the apex, it is actually sandwiched between the muscle, that is the sterno thyroid muscle and the inferior constrictor muscle. See, in this diagram it is clearly seen. Inferior constrictor muscle और ये sternothyroid है. ये दोनों के बीच में apex is sandwiched. That is the reason why whenever there is enlargement, this part cannot enlarge. Okay, so the apex of the thyroid gland cannot enlarge. Restriction होता है उसको. This is the thyroid cartilage और ये oblique line है. And this is how the attachment is present. Thyrohyoid, sternothyroid and inferior constrictor. और ये दोनों के बीच में apex आता है. Then few important things about the gland. There is a superior thyroid artery here which goes along with the external laryngeal nerve. दोनों साथ में ही आते हैं. लेकिन जब वो apex of the gland पे reach करते, whenever they reach the apex of the gland, they separate. Okay, and that is the reason one should keep in mind that whenever you are operating on the gland, the ligature for the artery should be very close to the gland. यहाँ पे ligate करेंगे तो हम वो external laryngeal nerve को damage कर सकते हैं. So at the upper pole of the gland, ligature should be tied close to the gland. Why? To avoid injury. To which nerve? To external laryngeal nerve. MCQ question है ये. Similarly, inferior part of the lobe को आप देखोगे, there is a inferior thyroid artery. Base of the gland, I'm talking about the base of the lobe. There is an inferior thyroid artery. Inferior thyroid artery goes with the recurrent laryngeal nerve. And when they are entering, they are very close to each other when they enter the substance of the gland. But थोड़ा दूर देखोगे तो they are away from each other, which means that the ligature should be tied away from the gland at the base. Why? To avoid injury. Avoid injury to which nerve? To avoid injury to the recurrent laryngeal nerve. Once again, I'll repeat. At the apex of the gland, ligature should be tied close to the gland, and at the base, it should be tied away from the gland. This diagram again clearly mentioned here. ये दूर जाते हुए दिख रहा है. So close to the gland, I will apply the ligature. See, when it is entering the substance, the recurrent laryngeal nerve is very close to the artery. So at the base, the ligature should be away from the gland. This is asked everywhere till your third MBBS until you become surgeons. This is very important. Okay, so we are discussing this now. This is the thyroid gland. So we have seen this, how the gland is enclosed by the fascia. So if I want to see the anterior layers, I will see that there is skin superficial fascia, there is deep fascia, the skin superficial fascia, and then with the deep fascia I can see these muscles. Sternocleidomastoid hai, this is sternohyoid hai, sternothyroid hai. Uske baad I come across the pretracheal layer and then the thyroid gland. Okay, so these are the structures which I have to pass when I am operating on a thyroid gland. Deep relations of the gland, if you see, same diagram, schematic hai ye. This is the thyroid gland. The medial surface is related to two tubes, trachea and the esophagus, two muscles, the inferior constrictor muscle, यहाँ पे this diagram, and the cricothyroid muscle, or you can see this part, posterior part है लेकिन. Then two nerves, the external laryngeal nerve and the recurrent laryngeal nerve. And posterolaterally, it is related to carotid sheath and its contents. Okay, so what we saw, deep relation, trachea, esophagus, posterolaterally carotid sheath. Also medially it is related to the two muscles, inferior constrictor, cricothyroid, and two nerves, external laryngeal and the recurrent laryngeal nerves. Here you cannot see the other relation. Here you can see only these two relations, two tubes and the sheath. Okay. Anterior border, this becomes the anterior border. This is the anterior border. So the anterior border of the gland is thin. It is accompanied by the anterior branch of the superior thyroid artery, which means that the superior thyroid artery divides at the apex into two, anterior and the posterior branch. The anterior branch goes along the anterior border and the posterior branch goes along the posterior border. Posterior border is slightly thick. So posterior border is related with the posterior branch of the superior thyroid artery and branch of the inferior thyroid artery. So we can also say that the posterior border shows anastomosis between the superior thyroid and the inferior thyroid artery. So this is the anterior branch, this is the posterior branch. Very easy diagram to draw, you can draw in your exam. Isthmus, the upper border of the isthmus is related to anastomosis between the anterior branches of both the sides. Inferiorly, there are veins present or thyroid ema artery. We will come to this artery, and it lies in, it is usually covered by second or third ring of the trachea. It usually covers, it lies in front of second or third ring. Okay. Now, so this is something what is interesting, what we can see here. हमने दो ही लोब के बारे में पढ़ा, ये क्या है? So sometimes a third lobe called a pyramidal lobe can be present, which comes from the upper part of the isthmus. That's all. Okay. और इतना ही हो सकता है ये लोब, और there can be a muscular or a fibrous band which is going from the pyramidal lobe towards the hyoid bone. And when it is muscular, it is known as levator glandulae thyroidae. Okay. So this is something which may or may not be asked, but then I think it is easy to remember. ये पिरामिडल लोब के बारे में है, और यहाँ से अगर मस्कुलर कुछ गया ऊपर हाइयोइड बोन तक, so that is known as levator thyroid. It elevates, no? So arterial supply. By this time we actually have discussed all the blood supply, but now this is a quick revision. The blood supply of the thyroid gland is by superior thyroid artery, which is a branch of the external carotid artery. Some books mention that superior thyroid artery is the first branch of the external carotid artery. It goes towards the superior pole, divides into anterior and posterior branch. Inferiorly, it is supplied by the inferior thyroid artery, which is a branch of the thyrocervical trunk, which is coming from the subclavian artery. Anastomosis occurs at the posterior border between the superior and the inferior, and upper border of the isthmus between the two anterior branches. Superior thyroid artery. Again, this to show you the anastomosis and the relation between the nerves. In 10% of people, sometimes an artery called as thyroid ema artery, or in Latin you can call it as arteria thyroidea ema. It arises directly from the brachiocephalic trunk or arch of aorta. So there is a variation. It can occur directly from the brachiocephalic arch of aorta, or it can also come from the right common carotid. Okay. Now this is very important because one should know while operating that there can be such artery present. So I will only like get superior thyroid, inferior thyroid, and if I start operating and this bleeds, this is directly from the aorta. Okay, so it will cause severe bleeding and it can be fatal. So one should know about thyroid ema artery. This is to show you the posterior border and how the parathyroid glands lie at the posterior border. So parathyroid glands are supplied by the inferior thyroid artery. Schematically represented. Venous drainage. We know there is a thyroid plexus of veins which lies deep to the true capsule. So venous drainage is usually by superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein going into the internal jugular and the brachiocephalic. Again, sometimes there can be a Kocher's vein. This is the inferior thyroid vein. Sometimes there can be a Kocher's vein present. One should know this again for operating. While operating, one should know that there is a Kocher's vein present, just like thyroidema artery. This is the inferior thyroid vein, superior thyroid and middle thyroid. Same, just to show you that schematically it looks very nice, but actually it is completely filled with blood vessels. So you should be very careful. See, showing vein of Kocher. This is the inferior thyroid veins. So it should be ligated if present. Lymphatic drainage. Upper group or the upper part of the thyroid drains into the pre-laryngeal, larynx के आगे, jugular digastric, jugular vein और the digastric है यहाँ पे muscle. So ये दोनों में drain करता है. Inferior group will go towards the pretracheal and lymph nodes present along the recurrent laryngeal. This is to show all the blood supply, nerve supply, venous drainage and the lymph nodes. Prelaryngeal, jugular digastric, pretracheal and lymphatics along the recurrent laryngeal nerve. Nerve supply, of course, again we have seen it, we'll quickly revise. Parasympathetic is by the vagus and the recurrent laryngeal. ये है यहाँ पे recurrent laryngeal. Sympathetic derived from the sympathetic ganglia, superior, middle and the inferior. The sympathetic trunk. Superior sympathetic ganglion. This is just to explain about the external laryngeal nerve. It is the superior laryngeal nerve which divides into internal and external. In dissection, this nerve is very nicely seen and you can see the internal laryngeal nerve piercing and going in. So the nerve which lies outside is the external laryngeal nerve. Applied anatomy, thyroidectomy. Of course, we know that removal of the thyroid gland. क्या करना है? Ligation near the gland at upper pole, away from the gland at the lower pole to take care of the nerves. Then ectopic thyroid gland can be present apart from the normal place. That in embryology you must have seen it, developmental anomaly. Accessory thyroid gland, just like accessory parotid gland, what we have seen. The glandular tissue can be seen apart from the thyroid gland, it is seen nearby. Okay, that is also known as accessory thyroid gland. This is to show you the relation between the artery and the nerve at the lower pole. By seeing so many pictures, I think it will remain in your head and you will not forget this. It is asked everywhere. Viva, MCQ, short note. See this. So injury to the recurrent laryngeal nerve will cause hoarseness of voice, and injury to the external laryngeal will cause monotonous voice. Enlargement of the thyroid gland is known as goiter. Okay. So this is all about thyroid gland. Thank you.